Okay, well, thanks very much for Cohen and Dallas especially for inviting me. So a lot of colleagues and friends in the audience. We should have a smaller room. And so I just want to give a little story. When I was a neurosurgery resident, people with severe, so back when I was a resident, coma was the big deal. Concussion, I don't know if they even called it concussion. It was something you saw in the ER where they had a normal scan, you sent them out. But one thing, when somebody came in with a severe traumatic brain injury, it was 50-50 that they would pull through. It was a 50% mortality at that time with severe TBI. And I got together with a number of my colleagues, Randy Chestnut and Don Marion, and we were lamenting on the fact that we go out and give lectures about how to take care of severe traumatic brain injury. We found a lot of our colleagues were giving steroids. They weren't monitoring brain pressure. They're hyperventilating their patients. All the stuff that we knew that was wrong. And that's when we founded the Brain Trauma Foundation. We did the guidelines. And guess what? We stopped that. Every trauma center now, talk about implementation science, every trauma center has to use the Brain Trauma Foundation guidelines. They're checked on it. There's monitoring. The American College of Surgeons monitors it. Guess what? The death rate dropped from 50% all the way down to 20, okay? No pharma, nothing else, just changing the variability of practice. So what about concussion? The big tofu in the room, oh, sorry about that, David, it's okay. The big tofu in the room, there you are, is not concussion, but the way concussion's being treated. We have a whole nother disease called brain rest and body rest, that we have a whole population of people who have, and I'll come to my domain in a minute. We have, I get to talk about this. I'm really passionate about this. I have all these patients coming to me, and so at Stanford Sports Medicine, I see all the athletes within 24 hours, completely different crowd than the Neuroscience Health Center where I have a 3-month waiting list where they wait to come and see me. And meanwhile, while they're waiting, the primary care physician is saying, don't look at bright screens, don't exercise, you have a brain injury, very serious. Don't get any symptoms. If you get symptoms, the brain injury get worse. So 3 months later, I have people that are psychiatric. It's a whole, that population, I believe, we should do a survey, is much bigger than the ones that get hit and seen and treated quickly. It's a whole other problem. And so just like the severe TBI guidelines, is stop people from doing dumb stuff. The same thing should be done on concussion. It would be remarkable. Thank you, David. So I know we don't have it here. We're very science-oriented and all that, but you got to see what's happening on the outside. And we've had some speakers here talk about it. What's really going on in primary care? What's going on with people taking, and the big thing is, and not exercising, by the way. Early cardio exercise. When I came to Stanford, they had the athletes. These are athletes. They told them, don't exercise. And boy, did they take a long time to recover. And so I tell all my patients, early cardio exercise is huge, and we don't do enough research on it. Prevents dementia, heart attacks, strokes. It's great for recovery, brain resilience. I mean, it's amazing what it does for recovery and concussion. Okay, let's get into the science. So I came on this thing. The phenotypes, I like the phenotypes because we were struggling. We published concussion guidelines, step 1. We did a review of all literature. We found that attention and balance were impaired, big deal. It didn't say much. And then in the meantime, the Pittsburgh group, Mickey Collins and Anthony Contos and a bunch of other people from around the country had this big meeting, team meeting, and guess what? They said, what do we see in the clinic? Very smart. They said, what do we see in the clinic? And they came up with these subtypes. And so now we've formed a collaboration, and David's on the task force as well. And we've recognized that there are clinical phenotypes, subtypes. There's different words for this thing. Probably phenotype is a better word than subtypes, because subtypes implies that one subtype has a different biology from another subtype, whereas really they can be combined, and there's clustering and trajectories, which we'll get into. But anyway, so hats off to the Pittsburgh people and the team. And so we're about to come out in neurosurgery right now is concussion classification, concussion guidelines, step 2, evidence for subtype classification, okay? So in there, we're going to show that there's prevalence of these subtypes compared to normal populations or baseline. So what's the overview? The overview, it's about phenotypes, but we want to transition to biotypes. What's the biology behind it? So it's a focus on post-concussion clinically prevalent impairments and symptoms, and we call those clinical phenotypes. And what we'd like to do is propose as a new classification, and it's useful because in those diagnostic categories, there are specific treatments that you can give to patients and make them better, obviously adding exercise, which is my favorite. So the top takeaway from this, oh, it's switching here, not there, okay. Where are we? Okay, yeah, no, let's do the next one. So the top takeaways from multiple conversations was, okay, I mean, when we first started talking, it was like, we're going to take on all of TBI, concussion to coma, very big area. So we said, let's try and focus on areas we can make a difference, and so the when became important. And we started off with saying 3 months, let's start at 3 months post-concussion where symptoms are stable, people haven't recovered, maybe we can intervene and do something for them. But then Anthony Contos brought up this thing, well, you know that if we treat them early, then they won't you won't see them at 3 months. You know, so you do the right thing early on, you won't see them at 3 months. So I thought that's useful. So 2 time points, one initially, and then another one 3 months later. And then, of course, what else impacts these phenotypes? It's the setting and the mechanism. When you see an ER patient, or you see somebody in a clinic 2 months later, it's very different from seeing an athlete right away. Completely different presentations and the way you treat them. So, and then the who, the age, seeing a kid or an elderly person makes a big difference. Female, the gender effect is in there as well. And then what about what they had before? I call it the baggage you bring to a concussion. Everyone brings baggage to a concussion. They have prior migraine headaches, they have mood disorders, they have sleep apnea, they're not exercising, all sorts of things. So you have to put that into consideration. And then what do you want to do? You want to have more objective measures. If you look at, actually, if you want the FDA to approve like the best thing to diagnose concussion, you do a symptom inventory. It's a SCAT-5 inventory or the post-concussion symptom inventory. They're actually, the severity and the loading of symptoms is 100% diagnostic with a physician's diagnosis of concussion, because the physician's diagnosing it based on symptoms. It's circular. So we have a circular problem here which needs to be solved, is that the actual gold standard for concussion diagnosis is a headache after a head injury. And that's what all our objective measures are trying to target, but really, that's not it. So we need to make a transition from that. So the gaps, what are the gaps? What's the evidence for that? We're about to publish that. But the next thing is, how do they cluster? So has somebody with a headache or mood disorders and vestibular problems, are they different in terms of trajectory and recovery compared to somebody with just ocular motor and depression? And then what's the evidence for the current treatment? So how do different phenotypes and clustering respond to different treatments? And then finally, we want to make a transition from phenotypes to biotypes. We want to know what the biology behind this is. And everyone's got their pet theories, but what's going on behind these clusterings? If we see the clinical clusters, then we can go back and look at imaging, biomarkers, and so on, and come up with better biology of what we're doing. So come to our section meeting this afternoon and give us your opinion. Love to hear it, both from science and clinical people. It'll add a lot of value. Thank you.